This is a small video on pediatric final year Viva on immunization. We will be discussing the core issues concerning the students in Viva, on table Viva or in any OSCE station. So we have to understand that there are two basic types of vaccines: live attenuated and inactivated vaccines. And all the live vaccines, they are administered either orally or subcutaneously or intradermal in the case of BCG, but never IM. This is the core fact. And you can pause this slide and read this further. The site of vaccination, the oral vaccines are rotavirus and OPV. The anterolateral thigh, we have two vaccines. Left side hepatitis B or pentavalent, and in the right side it is pneumococcal conjugate vaccine. Intradermally we administered the BCG and fractional IPV. BCG is administered on the left upper arm and fractional IPV on the right upper arm. Measles and measles containing vaccines and JE are administered subcutaneously. Measles is put in the right arm and J in the left upper arm. At birth we have BCG, OPV and hepatitis B. A core series of 6, 10 and 14 weeks contains OPV, pentavalent and rotavirus. Two vaccines additionally are given at 6 and 14 weeks. They are fractional IPV and pneumococcal conjugate vaccine. At 9 to 12 months, under the National Immunization Program, we have measles containing vaccine, MR first dose, JE1 in endemic districts only, pneumococcal vaccine booster, and start of vitamin A prophylaxis. At 16 to 24 months, we repeat the measles containing vaccine and JE. Now we give the DPT booster, OPV and vitamin A 2 lakh units orally. When the child is 5 to 6 years, we give DPT booster and TD vaccine at 10 and 16 years, and OPV as part of pulse polio program continues to be given till 5 years of age. There is some divergence between NIS and IAP guidelines. Fractional IPV is given at 6 and 14 weeks in NIS, and IAP recommends IM doses 0.5 ml at 6, 10 and 14 weeks. Similarly, IAP recommends MMR instead of MR and gives a dose at 4 to 6 years also. And IAP also integrates the optional vaccines which are not included at all in the government program, National Immunization Program. Particularly, IAP lays focus on varicella vaccine, influenza vaccine and human papillomavirus vaccine. HPV vaccination has started in government schedule also, and soon it will be part of nationwide immunization program. Now, what are the common Viva challenges to the students in the pediatric examination? Often we find that the students are very confused and start answering the question, or they don't know the protocol of answering the question when it comes to vaccines. So we should have a particular flow and good knowledge about the vaccine. A suggested flow is that whenever you are asked to pick a vaccine, instead of examiner prompting to you, start speaking by yourself, like what is the type of the vaccine, what is the dose, how it is given, what is the route, where is the site of the vaccine, the schedule in the National Immunization Schedule or the IAP timeline, when can the catch-up vaccine be given, adverse effect of vaccination, if there is any particular to any vaccination, or any absolute contraindications. At least we should start by the saying the type, dose and route of the vaccine and the schedule of the vaccine. Now, in BCG vaccine, often the students make a mistake of dose. Remember, below 4 weeks it is always 0.05 ml intradermal, and above 1 month it is 0.1 ml up to 1 year of age. The second is the route confusion. Remember, all the pentavalent, pneumococcal, hepatitis B, DPT or tetanus, they are all subunit vaccines and they are all given as intramuscular vaccines. The BCG and IPV are given as intradermal. Subcutaneously we give measles, JE and varicella. Oral we have OPV and rotavirus. In the left mid thigh we give pentavalent and the other toxoid containing vaccines like DPT and hepatitis B. In the right we give the pneumococcal conjugate vaccine. This should be remembered that it should be spoken as mid thigh, not the thigh, and never say gluteal region, because as a rule no vaccine should be given in the gluteal region. This is again the map of site of vaccination. The JE and measles are given as subcutaneous. Fractional IPV and BCG are given as intradermal. BCG and JE are given on the left side. Fractional IPV and measles containing are given on the right side. Another favorite question of examiners is about the diluent used to reconstitute the vaccine. The vaccination is some of the freeze-dried vaccines like BCG and measles containing vaccine, they are diluted. BCG is diluted with normal saline and measles containing vaccine is diluted with distilled water and not the normal saline. Vaccine vial monitor is another very important common question area of the examiners. It is located on the cap where we do not have an open vial policy. For example, the freeze-dried vaccines of BCG, measles and rotavirus. On the label side, you will find the VVM in government supplied vaccines where open vial policy is applicable. That means once the vial is being used, it can be used up to 28 days under proper storage conditions. The vaccine vial monitor tells us the viability of the vaccine. Now, whenever the inner square becomes same color as the outer circle, it means we have to stop the usage of this vaccine. If it is lighter or it is completely white, the vaccine is perfect to use. Second important point that you should remember is expiry date of the vaccine. VVM may be intact but the expiry date may be over, so don't use that vaccine also. There are some specific side effects to some vaccines which are very favorite questions of examiners. Rotavirus particularly causes intussusception in some patients. Pertussis has specific side effects of inconsolable crying, hypotensive, hyporesponsive episodes. Measles containing vaccines can create toxic shock syndrome. OPV can cause vaccine associated paralytic poliomyelitis, and BCG as complication can cause suppurative lymphadenitis or localized osteomyelitis as specific side effects of these vaccines. There are absolute contraindications to some vaccines. If there is any progressive neurological disease, we do not administer any pertussis containing vaccine. Remember, cerebral palsy is not a progressive neurological disease, so CP patients can be given pertussis containing vaccine. Severe immunodeficiency or symptomatic HIV patients like AIDS patients should not be given any live vaccines like BCG, OPV, measles or varicella. If there is history of any anaphylaxis, obviously we have to stop the usage of vaccination in that particular vaccine. And if there is any encephalopathy within 7 days of previous dose of pertussis containing vaccine, that becomes a contraindication to further doses of pertussis vaccine. Remember, mild fever, cough and mild diarrhea are not the reason to withhold any vaccination. Seriously ill children admitted in hospitals should never be given vaccination as a rule. Now, some what if scenarios are put by some examiners. So, real life situations like child vomiting after the oral dose or any patient coming unvaccinated completely at a later age, these are the common favorite questions. You can pause this video and see the situation. Accordingly, we should always have a vaccine blueprint. Like this chart represents all the vaccines and what is the diluent, what is the site, what is the route, and whether any open vial policy applies or not. BCG can be given up to 1 year. Rotavirus, pentavalent and IPV all can be given up to 1 year. They cannot be given beyond 1 year. OPV can be given up to 5 years. Measles containing vaccine can be given up to 5 years. DPT containing vaccine can be given up to 7 years. And JE vaccine can be given up to 15 years. This is the logic of successive doses when you start the catch-up regime of the vaccines. The booster dose of this regime should be at least 6 months to 1 year after the primary series is over. Now these are the two scenarios where the unvaccinated infants have come for vaccination, and you can see the age appropriate schedule has been put, and some vaccines are omitted beyond 1 year, and the schedule is given like that. One rule to remember is, if suppose a patient has got vaccination at 6 weeks or 10 weeks, that dose has to be calculated as already given. That should not be repeated. There are some adverse events following the immunization. They can be vaccine related, quality problems, they can be program errors, they can be associated with anxiety of the patient, for example, the older adolescents, or it can be coincidental any illness which could have caused the adverse effect. Now, immediate anaphylaxis or syncope could be due to any vaccination, but inconsolable crying or encephalopathy is particular to the pertussis containing vaccination. Toxic shock syndrome also is one event which occurs very soon after the contaminated measles containing vaccine. Interception, vaccine-associated poliomyelitis and osteomyelitis, they are delayed effects of the adverse effects of the vaccines. Now you can see in this slide that AEFI can be of program error, manufacturer error, and through this algorithm we can locate where the problem lies. So finally, we should remember that you should use the 8.4 framework of dose of vaccine, the type of vaccine, site of vaccine, schedule of the vaccine, side effects, etc. And never falter on the doses, the route of the vaccination, or the diluent. Always see whether the vaccination follows the open vial policy or not, and vaccine vial monitor is the main core area. Thank you for watching this video and hope it is very useful for your upcoming examinations. Good luck, friends.